I'm Dr. Bob Jones, and welcome to the Introduction to Renal POCUS video. By the end of this presentation, you're going to be able to identify the normal sonographic findings of the kidney, identify sonographic findings associated with obstructive uropathy, particularly hydronephrosis. You'll be able to, this afternoon, demonstrate these exams for us and list the clinical applications of them, and also be able to discuss exam pitfalls. So comprehensive renal ultrasound can be used in a wide number of clinical settings, such as evaluation of renal masses, renal trauma, renal infection, renal failure, obstructive uropathy, transplant evaluation. But what we're focusing on with the POCUS exam is the patient with suspected obstructive uropathy, really looking for, is there hydronephrosis present? And the icing on the cake is, can you ideally see the stone? And at the bladder level, does this patient have urinary bladder distension? So while it's very easy to click on the CT renal protocol, examine your electronic medical record system, there's risks associated with that to the patient, and particularly it's ionizing radiation. And since renal stone disease is a common presentation to the emergency department, and this is a recurring problem for patients, they can get multiple CT scans over a period of time and have significant ionizing radiation risk exposure because of that. So a sonography first strategy is a very viable and important one to consider. So when we do these exams, we're basically using the perihepatic, perisplenic, and pelvic windows from the FAST exam. So these are crossover windows, again, you're familiar with. So again, patients supine or potentially decubitus, lateral decubitus position. We're going to be using the, in adults, the 5 to 2 megahertz, either curvilinear or phased array probes. You always want to make sure you're in the correct preset. You don't have to do any patient prep. You don't have to wait for them to be NPO for 8 hours. And sometimes you can obtain better windows by having the patient take in a deep breath, because it pushes things in a caudal direction. So that may be something to try during the exam. So let's first look at the renal part of things when we're evaluating for obstructive uropathy. So we're going to be able to, with ultrasound, see the renal parenchyma, the corticomedullary junction with the medullary pyramids, and the renal pelvis, which contains the calyces and the vasculature. So from a sonographic standpoint, and here we're looking at the right kidney, you can see that here you've got the renal parenchyma, which is hypoechoic to the renal pelvis here. Sometimes you're going to see the medullary pyramids, which are normally less echogenic than the surrounding parenchyma, and sometimes they may appear anechoic. The kidney should be less echogenic on the right side than the liver. And that's important when you're looking, for medical renal disease or more chronic, etiologies, because then you'll notice that the kidney becomes, smaller than these number ranges here and more echogenic. But that's really not what we're looking for with the, the suspected obstructive uropathy exam. And it's important to remember, you're not going to see the calyces or the ureters unless they're dilated. Sometimes patients will have very prominent medullary pyramids. They'll appear anechoic here at the corticomedullary junction, but taper towards the pelvis, and you don't want to confuse them as hydronephrosis. So we're basically doing coronal exams of the kidney using perihepatic and perisplenic windows. So you're going in between the ribs, somewhere between the 8th to 11th intercostal spaces. Here you're going to be more mid-axillary. Here you're going to be more posterior axillary, because the spleen is not providing a good window indicator towards the head. Since we're looking for hydronephrosis, make sure that you're cutting through the pelvis. If you're only getting part of the pelvis or none of the pelvis, then you're going to be underestimating the potential finding of hydronephrosis. So here we've got a coronal view here on the right side showing that we're going lateral to medial. There's head to foot. Here's liver. Here's parenchyma. Here's pelvis. You can see that we've got the opening of the renal pelvis. So this is a good window to rule out hydronephrosis. On the left side here, same thing. Lateral to medial, head to foot. We got a little bit of the inferior part of the spleen here, and here we've got parenchyma, hyperechoic pelvis. The kidney is hypoechoic to the parenchyma of the spleen, but here we're not seeing the opening of the pelvis, so we would have to adjust our beam here in order to get a better view if we're really trying to rule out hydronephrosis. You can also, by rotating 90 degrees counterclockwise, you can also get a transverse view. This will give you, in a sense, a CT axial view. So anterior, posterior, right and left, you've got liver and you've got kidney here. But predominantly we're going to be doing the coronal, which gives us a long axis view of the kidney. You may find that the patients have, in terms of variants, duplicated collecting systems. Very common, and here's a patient, here's two collecting systems, and they've got a stone obstructing in the one by the inferior pole here. Patients may have horseshoe kidneys. And here we've got a patient here. You can see the CT scan here. And here you can see the ultrasound, so anterior, posterior, right and left. And you can see the horseshoe kidney, and you can see the presence of the calyceal dilatation on this side. This was a patient that had an obstructive uropathy there. Many times these patients are unaware that they have, a horseshoe kidney. But what if you don't see a kidney? So here's a patient scanning on the right side, and you can see the kidney, or not the kidney, you can see the liver and the psoas muscle, but there's no kidney interposed there. So now maybe they did have true renal agenesis there and never developed a kidney on the right side. But we have to think about renal embryology. The kidneys ascend from the pelvis up, to their adult position in the flanks. And so if you don't see a kidney in the flank region when you're scanning, then follow that path down to the pelvis. And here's a sagittal view, anterior, posterior, head and foot. And this is a pregnant woman, and you can see that there's her uterus with the pregnancy there. And just cephalad to that, what you can see is her kidney. So she has a pelvic kidney. So don't forget about that. So directly related to suspected obstructive uropathy, we're looking for presence of unilateral hydronephrosis. Is there potential perinephric fluid, which in these cases are urinomas because of rupture due to pressure of the minor calyces? You may see hydroureter if you're able to follow it down, but that can be a little bit more technically difficult. So we're really focusing up here on, is there hydronephrosis? You may see a stone if it's in the very proximal region here. And down by the bladder, then you may find also a distal UVJ stone, and you may see decreased or absence of urine jet. It's important when you consider hydronephrosis to think about, is it unilateral or bilateral? So in order to determine that, you have to scan both kidneys. Because if you've got unilateral hydronephrosis and you're expecting obstruction here somewhere or here somewhere, if you've got bilateral, then that would mean they have bilateral ureteral stones, or they've got something more distal like a bladder outlet obstruction. So just keep that in mind in your differential. Also stop for a second here and think, if you see hydronephrosis, that's just a surrogate for, letting us know that there's ureteral compression. That could be intrinsic or extrinsic. If you don't definitively see the stone, you have to be thinking about other things. In the older person, you may be thinking of masses that are doing this. And on the left side, one to always think about is abdominal aortic aneurysm. That could cause left-sided hydronephrosis. So if they've never had imaging in your electronic medical record and you don't see anything evaluating the aorta in the past, scan their aorta if they've got risk for AAA and they don't have any prior imaging. Also remember that hydronephrosis, again, as a surrogate, it could be absent in certain circumstances. Number one, these are extremely painful when patients develop urinary or ureteral stones. And so they may come in very acutely. If they do, the hydronephrosis may not have developed yet. And depending on the degree of obstruction, that may affect hydronephrosis development. Or some of these patients, due to multiple episodes of vomiting, they're dehydrated, and they may not develop it. So absence does not rule out. How do we grade this? Basically, we're going from mild, where you can see some, dilatation of the renal pelvis going towards the minor calyces. Now you're seeing more dilatation of the pelvis and more visualization of the minor calyces. When you're at moderate, if you're at severe, you're really seeing more of the minor calyces as being well defined, and it has that bear paw sign appearance to it. And when it's chronic, what you're going to start noticing is thinning of the renal parenchyma. Normal renal parenchyma should be 15 millimeters. If it's less than that, then you're thinking of more chronic etiologies. When do you use Doppler? It's not a standard part of the exam, but remember, within the renal pelvis, you also have the vessels housed. So they could look sometimes like mild hydronephrosis. Here you can see this could be mild hydronephrosis. I've scanned coronally, I've looked transversely, and now I put Doppler on and all of this fills in. So this is just prominent renal vasculature, not hydronephrosis. Whereas on this patient, looked very similar, and I'm thinking, well, maybe this is hydronephrosis, maybe this is just a prominent vessel. I go ahead and I go transverse, and I put Doppler on, and I can see vessel, ureter. So this is a patient with true hydronephrosis. So when I use the transverse window, and Doppler, it's going to be when I have somebody with mild hydro, where I'm trying to differentiate a prominent vessel from hydronephrosis. What's a stone going to look like? Here you've got a large echogenic stone, a UPJ stone with posterior shadowing there. It's also important to keep in mind that you're not only trying to grade the hydronephrosis, but you're also looking at its sonographic appearance. If it appears echogenic, then in the context of potential concern for infection, you're thinking about pyonephrosis, or in trauma, you're thinking that this could be blood. But in simple hydronephrosis from an obstructing ureteral stone, the hydronephrosis should be anechoic. Anything echogenic should make you think of something more complicated. In terms of commonly encountered pathologies or normal variants, renal cysts, you're going to frequently see those, and they can be any location within the kidney, from the pelvis to the parenchyma. They can be very small, but all cysts have the same characteristic. They're anechoic, round or oval, and they have posterior enhancement. If they do not meet all of those criteria, they all require follow-up, whether that's renal, liver, splenic, testicular, ovarian. You have to differentiate a simple cyst from a complicated cyst. Some patients, may present with polycystic kidney disease. And these cysts can be variable size, variable location. Frequently they're bilateral. But the problem becomes when they're closer to the pelvis and you've got innumerable cysts there, it's going to be very difficult to differentiate hydro, from all of these, other cysts. So you have to understand that as a limitation. Anything, as I said, that is not, a simple cyst requires follow-up. This is a patient, came in, flank pain, hematuria. By the inferior pole has this rounded echogenic mass. The parenchyma should normally have a nice homogeneous appearance. There's this mass right there. This ultimately was diagnosed as renal cell carcinoma. Patients may also have things like dromedary humps, more common on the left side, that could simulate a mass. Things to be aware of. You may see junctional folds, very common to see those at the junction of the upper and middle thirds. It's the wedge-shaped hyperechoic defect. It's related to embryologic fusion. These are not renal lacerations. Some patients have very prominent, columns of cortical tissue that protrude down into the sinus that you may think, oh, that's a mass sitting right there. So these are all things that in the beginning, as you're doing it, you may not be able to differentiate, and that may lead you to get additional imaging. Don't forget about extrarenal pelvises. These can be anywhere from mild to very prominent, and these can mimic hydronephrosis. Here's a patient that this was done during a trauma exam, but if you take a look, there's marked dilatation here of the pelvis. We've done coronal as well as transverse, but what you can see is that there's very little dilatation that extends inward towards the minor calyces, which you would expect if this was truly due to an obstructive uropathy. But this was a patient with just a markedly dilated extrarenal pelvis. So when we're doing these, think about if you've got positive unilateral hydronephrosis without seeing a stone. Remember, it's just a surrogate. You can treat them as obstructive uropathy provided there's no other high-risk findings present. Now, your urology colleagues may not like that because they always want to know what the size of the offending stone is, but a lot of times, these patients pass it before they follow up, and if you can avoid getting them a CT scan, that's beneficial. If you don't see hydro on the expected side, then obstructive uropathy is less likely. You need to consider other causes, but remember, it doesn't rule it out. They may be because they're too early or they're dehydrated. If you've got bilateral, consider something distal, but also consider that they maybe do have, and I've seen this over the years, bilateral ureteral stones. If there's risk for AAA and you don't see the stone, and particularly if it's on the left, please scan the aorta. Bladder ultrasound, this is much better for the patients than putting in a Foley to test how much urine is in there. And you're basically doing your pelvic window with a fast exam, sagittal, transverse, and you're doing the plus sign and the minus sign. You're taking 3 orthogonal measurements to get your bladder volume. And you can do this, post-void, you could do this pre-void, but this is a very, non-invasive and quick thing to do. Lastly, you can look at urine jets. Those are just qualitative. You go transverse, you go by where the trigones come in posteriorly. Here we have a patient with the distal UVJ stone, and it's behind the twinkle artifact that was just there. And you could see the large jet on the left side and the smaller jet due to the obstruction on the right side. But these are just qualitative. And that concludes the POCUS renal and bladder lecture.